Hello, everyone. We're going to go ahead and get started. So this is a two-part session today. In the first part of the talk, we're going to have Liz Stabe from my office, who is going to talk to you about a very important topic on building resiliency in medical school. So Liz is going to speak until about 1:10, and then at 1:10 we have Dr. Mike Kirchhoff, who is an emergency medicine physician and who is also Cooper's patient safety officer. He's going to come over and he's going to do the training for hand hygiene. You guys need that before WOW. So we're going to get everybody trained today so that everybody's ready to go into the hospital. So without further ado, here's Liz Stabe.
Okay, can you hear me? All right, so I have this microphone because I'm a wanderer. So we're going to talk about resiliency in med school today. So first we're going to talk about your journey. So this is how you started off. You were all starry-eyed. And then this happened. And this is what your schedule starts to look like. And then this is what you start to feel like. And then your journey's off track. So we're going to talk about how to rebound and ways to stay on track. So some of these are headlines. This is a pretty serious topic. I know I started off a little light, but this is a pretty serious topic. These are some headlines that are in the newspapers and in the news about medical student suicides and death. This is another one. Why do doctors commit suicide? And it's, somebody went through and said, I know they were so excited, just like I was. And then what happened? So I know you've seen the iceberg 1,000 times, but it's true. We only know what's on the top 10% of anybody we see, so we don't know what everybody's going through. We don't know what things are going on under the surface, and I will speak from experience, and the M2s can agree with me or not agree with me. The M1s probably haven't done this yet, but you all start to compare yourselves to each other. Everybody else looks like they're doing fine, right? And we don't know. So I want you to really think about the next two slides. So every year, an estimated 300 to 400 physicians, it's more close to 400, commit suicide every year. That's like one medical school dying every year. How many students do we have right now? Almost 400. So that's a pretty serious problem in the medical community, right? So I know that we bang this into your head and we talk about this a lot, and you just had last week or the week before Finding Courage by the SAP program, but this is why we talk about it all the time, because it's so incredibly important. So there are just some general risk factors for distress: sleep deprivation, you don't have a good school life balance, anger, loneliness, anxiety about your competency, right? We all go through the imposter syndrome, where we do something and we think, somebody's going to figure out I really don't know what I'm doing. Okay, so we all experience that. Even me in my profession experienced that when I was early on. Difficulty unplugging after school. So those of you that have had your meetings with me know one of my famous lines is, please don't lose touch with your hobbies. They're so incredibly important. So you have to be able to unplug. Using drugs or alcohol. Drugs and alcohol don't help the situation. They numb it for a minute, and then they add to it. Stress about school relationships with each other, relationships with maybe your significant others in school, relationships but with your roommates, your teachers, all those things. So depression. This is how it's diagnosed from the DSM, okay? So a major depressive episode includes persistent sadness, anxiety, or empty mood. If anybody has questions about what any of these things mean, feel free to yell out. Feelings of hopelessness or pessimism. Has anybody had that yet? Nobody in this room has had that yet? That is fabulous. Feelings of guilt, worthlessness, or helplessness. Loss of interest in pleasure or hobbies and activities. Any activities. Decreased energy or feeling fatigued. Anybody experience that? Difficulty concentrating, remembering. You can't sleep. You sleep too much. That's another one. You have no appetite. You overeat. Thoughts of death or suicide or an actual suicide attempt. Restlessness and irritability. So what happens when we'll use the kitchen trash. No one likes to take out the kitchen trash, right? So what happens when you keep stuffing and stuffing and stuffing? Then you order a pizza for dinner and you're like, what am I going to do with this box? I don't want to take out that trash. And you stuff it in there. What happens to the bag? What? Right. So that's what happens to us, right? So when we stuff and stuff and stuff and stuff, we have this little emotional trash can inside of us. We break. And when we break, things like this happen. We get irritable, we get tearful, we get, we don't have good frustration tolerance for people or things. We can't concentrate. All of these things start to happen. There are also physical symptoms that go along, so somatic complaints, headaches, stomach aches. You ever notice like when you're anxious, it's all in your belly and your intestinal region? So this is a graph it's from 2016, but all the data was collected in 15. And it's across, male, female, ages, races, and ethnicities. And it's the rate of depression in the US. So depression impacts everybody. None of us are immune. It doesn't only hit, men in their 50s who are retiring, or women, in their 20s who are starting college. Like, it doesn't only hit a certain classification. It can hit anybody. And I tell med students all the time, this is the hardest thing you've ever done in your life. You're used to being top of your class. Now you've come to a school with all the tops of all the classes. And that's a struggle. Why doesn't it come to me as quickly as it did before? Why don't my study habits work the way they did before? Why are people doing better than me when I'm used to being the one that does the best? This is the hardest thing you've ever done. So don't be shocked if you have some signs and symptoms of depression. Come talk to us. So this is specific to physicians. So 4% prefer not to answer. 19% are clinically depressed, which means they are diagnosed with depression. 70% are colloquial depression, which means they feel blue, they're sad, they feel depressed, but they haven't actually been diagnosed. So if you look at this, 89% of physicians are depressed. Are you surprised at that number? What? So burnout. Burnout's a little different than depression, right? So burnout is a chronic state of stress. Okay, that's exhausting and creates cynicism and detachment. And so some of the symptoms of burnout are chronic fatigue, insomnia, forgetfulness, loss of appetite, anxiety, depression, anger, and somatic complaints like we talked about, headaches, stomach aches, Maybe you have some physical pains. But burnout is a little different than depression. It's not maybe as serious. It's serious, but not as serious as depression. So where do you guys think you live on this chart? You're going to have to participate. One side is your challenge level, the other side is your skill level. Where are the M1s living? Uh-huh. Right? Where are the M2s living? Right? So you live in worry, anxiety, and arousal all the time. So I go back to the question, do you start to agree with me this is the hardest thing you guys have ever done? Right. So how often do physicians experience burnout? They did a scale of 1 to 7. Okay, 1 is rarely, 7 is always, and this is how it broke down. So the highest percentage is at about a 5. So burnout and depression and suicide across the continuum. So this is the good news, right? So medical students, if you look, you're the highest on everything. When you become a resident, it goes down a little, a smidge. And then when you are early in your career, less than 5 years, it keeps going down. So let's hope the next column would be, in your career for over 5 years, it would be even lower. So there is hope, there's light at the end of the tunnel. It should get better. So know the warning signs, right? For yourself and for others. People isolate or withdraw. They used to always be the social one. Come on, let's go to the movies. Let's do something. And all of a sudden you call them or you try to see them and they're like, no, I'm tired. I don't want to do that. Right? So you start to notice that change. You start to notice the change in yourself too. You were always the active one. Giving away important possessions. Okay, that's an important one. Changes in personality or appearance. You have somebody who is always dressed to the nines. They always look great. Every time you see them, they are sharp. All of a sudden, they start coming to class in their sweatpants. Right? They're hanging out in the Victor building. Maybe they're in their pajamas. You're like, what's going on with you? Seeming tired, hopeless for more than a couple days. So when I was at Cooper, I met a lady. Her name was Karen Hess. She ran a presentation. She was a former Rockette. So you can imagine what her personality was like. And she had a saying. She said, you can visit Pity City, but you just can't live there. And I love that saying. So if you want to take a day or two and you want to visit Pity City and maybe you didn't get the score you wanted on exam, or maybe, I don't know, you got some disappointing news from home, or you were really looking forward to a package getting delivered and it got delayed, whatever takes you to Pity City, you can visit, but you can't stay. So you have to remember that. Seeming distant or preoccupied, right? Like let's say me, I'm a good listener. One of my best friends says I get paid to listen for a living. So all of a sudden I'm distracted and I'm not paying any attention, right? And those of you that have talked to me know I listen. All of a sudden I'm just off in another land. Sudden calmness or happiness after a time of depression. So when people make a decision to end their life, they will all of a sudden become happier because they've made a decision. And they're looking forward to things being better because in a depressed person's mind, that decision will make things better. And then self-medicating, right? Excessive drinking, overspending, gambling, or drug use, right? Maybe I use my brother's Adderall to help me study, right? Or I can't sleep, so, oh, my mom takes Ativan, so I just borrowed a couple of her Ativan to help me sleep. Oh, I drink a glass of wine. Well, maybe now it's 2 or 3 to help me sleep at night. Or I really need, a couple shots before I can go be social. So what are some barriers to seeking help? People will judge me. They'll see me differently. Someone will see. One of the biggest things we used to have over at the SAP program is somebody will see me come in the door. Nobody will see you come in the door. They're not paying attention, right? I won't be able to get the residency I want because somehow if I sought help, it'll go on my record and it'll be counted against me. The school or my course directors will see me differently, will hold it against me, it'll impact my grading. Asking for help is weak. It's just a general feeling that people have. My patients get depressed, not me. I'm a doctor, I can handle this. Everyone around me is doing well. What's wrong with me? There goes that comparison thing that we talked about a couple slides ago, right? And I tell people all the time, if people looked at you, would they know you were struggling? 9 times out of 10, when I present that question, the answer is, well, no. So then what makes you think you can see someone else's struggle? We all are icebergs. We hide it very well. And a big fear people have is if I go ask for help, I'll get put on medication. If I tell someone I'm depressed, they'll want to give me a pill. I can't take medication because there's such a stigma around medication, right? And if you're someone that needs medication, then you need medication. If you had diabetes and your body wasn't producing insulin and you needed to be on medication, you would take it no problem. But because it's your brain chemicals out of balance, it's not okay. And that doesn't make sense if you think about it logically. Did I miss any? I don't think I missed any. So rebounding and staying on track, how do we do that? Exercise, right? Exercise is an excellent way. Some people go to the gym. I play tennis. I'd play tennis all day, every day if I could. I love it. Some people swim. Some people golf. Some people walk. I like to walk the dog. I don't like to walk myself. It's a little boring. But, there's all different kinds of exercise. Find what you like. And I hear plenty of you in the wellness room playing ping pong. That's exercise. And you're laughing and having a good time. And I wish I was in there playing. So find things to do. Burning physical energy, if you think about it, depression, anger, sadness, frustration, it's all a ball of negative energy swirling inside of you. If you can expend that in a positive way, it's gone, right? So do something physical. I'll say even clean the house, right? When I get mad, I clean. Because then when I'm done being mad, I have something nice to look at. So living in gratitude, it's not an easy thing to do. So I'm grateful for my parents, I'm grateful for my friends, I'm grateful for, whatever it is you're grateful for. I'm grateful I'm in medical school, whatever it is you're grateful for. But if we can live in a place of gratitude, it reminds us what's right. We are quick to think about what's wrong. So nobody will ever walk up to you and say, what's right with you today? But they sure will walk up to you and say, what's wrong with you today? So society trains us to be more negative than positive, right? So when something happens, we focus on what's wrong. If we go through an entire day, we make a whole list from brushing our teeth in the morning, which people say, well, that's not a big deal. But you did it, and it was right. You got up out of bed that morning. That was right. If we made a whole list of everything we do, the list of what you do right would outweigh the list of the things that went wrong. 10 times over or more. But when we look at things, we only focus on what went wrong. So live in gratitude. Ask yourself when you're in a tough spot, what went right today? What did I do right today? And even if it's something as simple as I brushed my teeth, it's still right. I ate something today, that's right. Okay, and the people don't give themselves credit for those kind of things. So friends, now you have to know your friends, right? Which friends do you need to be around when you're not feeling so great? Maybe you're sad, that are going to pick you up, right? What friends? People do different things for us based on their personality. What do we need and who can we get it from? One of my friends, David, went to law school, right? First year of law school, he got all A's and 1 B. Law school is supposed to be really hard, especially your first year. I didn't go. And he called his dad. His dad's very strict, and his dad said, what do you think his dad said when he said, Dad, I got all A's and 1 B? What do you think his dad said? Why'd you get the B? So then David called me, and he's like, oh, this is what my dad said. And I said, David, why didn't you call me first? Why didn't you call your mom first? We would have celebrated with you and then called your dad, because I know what your dad would have said. It's just who his dad was a very strict person. It's just who he is. So it's important that we know who we're going to and we are going where we're going to get what we need when we don't feel great. Family, same thing. Pets. So pets are very therapeutic. Like I said, I like walking the dog. That's fun. I don't like walking me. Right? So there have been studies done. Just being around an animal, petting an animal, playing with an animal decreases your depression and anxiety. It's also good for, okay, my dad has some heart issues, and he got a cat. And I was very happy because it's also good for some other stuff. You know, if he decreases his stress, any of that stuff, then his heart's going to be better, right? So I was very excited when he got the cat. Imaginary smoke break. How many of you smoke? Should I not ask that because you're in medical school? Let me not ask that. So, people that smoke say, I feel better after I had a cigarette. Is it the cigarette that made them feel better? No, because nicotine is an upper. What made them feel better is, what do you do when you smoke and you're inhaling and exhaling? You're doing deep breathing. Usually when you go for a smoke break, you step away from whatever it is that's upsetting you and you go outside or you go to a different area. There's usually people in the smoking area, so you're talking to people about other things. That's what makes you feel better, not the cigarette. So take an imaginary smoke break. Mindfulness. I'm going to show you 2 quick mindfulness exercises. Mindfulness is about being very aware in the moment you're in. So you wash the dishes mindfully, right? It's a very mundane task. What do we usually do? We usually think, what's on TV tonight? Or what homework do I have to do while we're washing the dishes? Well, if you mindfully wash the dishes, you pay attention to the water. What does it sound like coming out of the faucet? What temperature is it? What does the plate feel like when it's dirty? What does it feel like when it's clean? How does the soap feel on my hands or the sponge feel in my hands, right? That's how you mindfully wash the dishes. And it keeps you very present focused. So anxiety lives in yesterday and tomorrow. What happened? What's going to happen? It doesn't live in this moment. And if you experience a lot of anxiety and you can stay in this moment, the anxiety isn't there. Because in this moment, everything's okay. Work-life boundaries. So this is a struggle, I'm sure, for many of you. So work-life boundaries. I need to shut my computer off by 6 o'clock and go home and spend time with my family or my friends or whatever it is. I need to study for 4 hours, and then I need to turn it off and give myself an hour break, and then I can go back. I need to tell my friends I can't go out tonight because I need to study, but I can go out the next night. Okay? And a lot of things that I hear from med students is, I feel guilty if I didn't study. I'm not asking you not to study, but I'm asking you not to make studying the only thing you do. It's equally important to take care of yourself as it is to study. So there has to be a balance. So clothing. People like black. I'm not opposed to black. I'm in navy blue today. It's a dark color. But if you are not feeling great, okay, put some color into your wardrobe. Did you just say that? Right, you're totally colorful. I love it. Put some color into your wardrobe. You know, it's important. And it sounds like a simple and silly thing to do, but it works. Music and creativity. So music is great. Dance to it, you burn energy, right? Sing as loud as you want to sing. I tell people sing in the car, it doesn't matter. And laughing. You know, they actually have laughter therapy now. That's how healing laughter is. They do, I'm not lying. So 5 things. So I want everybody really quickly to think to themselves, what's something that stresses you out? Now put that thing in your mind. Now in your head, I mean, if we were alone, I'd ask you to do it out loud, but in your head, look around this room. What are 5 colors in this room? What are 3 things you can hear in this room? You're going to have to move a little to do this, but what are 3 things you can touch, and what do they feel like? Where's your anxiety? Right? It's not there. Because you just brought yourself into this moment. So that's something you can do anywhere you are. If you're in the middle of class and anxiety strikes, you can do this in the middle of class. Right? You can do it anywhere. Stop, breathe, and be. So you guys are all sitting, so you're going to walk. I can't do it because I'm standing. Well, I can do it because I'm standing, but... Okay, I want you to close your eyes. Go on a journey with me. So... it's a beautiful morning and you wake up and you say, oh, the birds are singing, the sun is out, it's a beautiful breeze. You know what? I'm going to take a little extra time and I'm going to have my favorite coffee or tea and I'm going to relax for a minute before I get dressed to go to work or school. So you get up and you get ready and you say, it's so beautiful, I'm going to walk. And you start walking. And I want everyone to start walking in your seats. You start walking. And you're noticing the squirrels and the bunnies and the flowers, and it's just beautiful. And then you realize, oh my goodness, I'm going to be late. I need to hurry up. I need to go faster. And then you go, oh, I had a meeting with my professor. I'm late. I need to get there. Stop. So how does that feel? Little low. Okay, so I want everyone to take 3 deep breaths. So how does that feel? Better? So this is something you can do anywhere. I'm famous for if I'm late to an appointment. You know, I get behind all the Sunday drivers that have nowhere to go if I'm late for an appointment. And I get there. And I usually pull into the parking lot and park, and then I do 3 deep breaths, because if I don't, I'll walk into that appointment going a little loopy. So what can we do for each other? We can talk about physician suicide. It's a real thing. Just because you talk to someone about suicide, it doesn't make them suicidal. You're not planting a seed, that's not what it does. But if we don't talk about it, then it stays under the radar and nobody's focused on it or paying attention to it. And if we want to stop it and prevent it and make those statistics go down, we have to be aware of it and talk about it. Be kind to each other. I know not always in life are we kind to each other. So be thoughtful about how we talk to each other and how we treat each other. Don't bully people, don't judge people. Reach out to someone in distress. If you see someone struggling, what's up? What's going on? What's wrong? Be a mentor, right? Lead by example. Know your available resources, and I'm going to give you some resources at the end. Invite someone who's struggling to join you at an event or activity. Hey, you want to come to the gym with me today? You want to go to dinner? You want to go visit Eva and get something to eat? Right? Because if somebody's feeling down and they're trying to isolate, the way to get them out of that is to invite them to do something fun. Ask for help to create a support system. So you guys are in ALGs together, and from what I understand, you all get pretty tight in your ALGs, right? So that's a new support system you have, right? So lean on each other. So what you permit, you promote. So if you allow something to happen around you, you say it's okay. So if I watch somebody make fun of somebody else, or if I'm in a conversation over here and we're talking about this person and it starts to go negative and I don't stop it or at least say something about it, I've said it's okay to make fun of that person. So silence is many times agreement. So this is a scenario, and it's a way that things you can use to kind of say, I'm not comfortable with this. So if you hear someone raising his or her voice of Vincent when you pass by and you're unsure of what to say, what do? So you use observation, feeling, need, and request. So you might say, I heard you speaking loudly to Vincent. I feel concerned because Vincent's having a hard time right now. I need everyone to be respectful at this hospital or in this school or on this soccer team or wherever you are, right? Would you be willing to lower your volume and speak with more consideration for Vincent's feelings? It's a lighter way and less confrontational and maybe more comfortable because not a lot of people are comfortable with confrontation. So here's your resources. Take a picture of this, whatever you need to do. At CMSRU, the Office of Student Affairs, that's my direct number. Okay, I am here for you guys all the time. And I tell people, I've had people say to me in the past, I don't want to bother you. You're not bothering me. My entire job is to help you. That's my whole job. And I signed up for it, so I must like it. So you are not bothering me. So please never feel that way and know that my door is always open. You can email me, you can call me, you can stop by. If I'm in the middle of a meeting, I can't see you, but we'll find a time. You can either wait till I'm done or we'll find a time to get together. Please, please don't hesitate to seek me out. Stop me in the hallway, wherever. I also tell people you can come in. I will celebrate your grades with you. I'm happy to hear how your weekend went. It doesn't always have to be because there's an issue. The Student Assistance Program. So across the street, down the block, in 3 Cooper Plaza, okay? And this is their phone number. You get 8 sessions with them, free, confidential. Dr. Rosengarten, she's your primary care, some of your primary care physicians. You can call her. If you're in distress or you see someone in distress, you can call that office and say, here's what's going on, here's what I need, what can I do? They will help you. Okay, Dr. Maymind. Dr. Maymind is on the SOM campus in Glassboro, and she is a psychiatrist, and we hold appointments for you guys with her. So if you need to see a psychiatrist, that's where you'll go. Okay, so it's not related to CMSRU, you'll get that, and that's separate, and we hold appointments for you guys. Local resources, there's a crisis center it's now Jefferson Hospital in Cherry Hill, and that's their phone number. And if you call them and say, I'm feeling suicidal, or I have a friend that's suicidal, they can give you resources, they will talk to you. And a national resource is the Suicide Talk Line. That's 24/7, and there are trained crisis counselors that man that line that will talk to you, that will either help you if you need help yourself, or again, if someone you know is in distress that you're concerned about, you can call them and say, I'm worried about one of my friends and this is what's going on and what can I do, and they will help you through that. There's also a bulletin board that I took a long time to make, so I hope you all come by and see it. And it's got all kind of resources on there for you. I even put up some celebrities with mental health disorders, so that might be an interesting list to look at and see who you find on there. But there's apps, there's talk lines, there's text lines, there's TED Talks, there's, what else do I have up there? Articles and things on the internet that you can look at on this topic about depression and suicide and stuff like that. Okay? Do you have any questions? Okay. Thank you for listening.
So while we wait for Dr. Kirchhoff to come, I just want to comment on a couple of things. I get this question all the time about what's disclosed in our office and how that is shared. Come on up, Mike. So if you come in and you have an appointment with Liz, she is not going to share what you say to her or any diagnoses with the medical education team. So I want to make that very clear that there's a firewall, an intentional firewall between the Office of Student Affairs and the Office of Medical Education. What we're trying to do this year is really open up the dialogue around this, and some of you know that I went to the AAMC last year and I was very moved by one of the sessions there, and it was on medical student and resident suicide. And they had one of the student affairs deans speak, and she was just fresh off of a medical student suicide. Actually, she was the one that found the student. So I never want any of you, any of us in this school community to be in that position. So we need to make it okay to talk about this. And I felt so impacted by that last year, the first thing that we did was set up the relationship between us and Rowan SOM so that we do have access to a psychiatrist. I pay to hold those appointments for you guys. And then what we did was lobby to get a position where we could hire a student support services specialist to be here in my office, and that's Liz's job. So we are moving forward on this. I do want to, again, open this invitation to you all to come see Liz, come see me, come see anybody in my office. We're here for you 24/7. So I'm going to turn it over now to Dr. Kirchhoff. Dr. Kirchhoff is an emergency medicine physician and Cooper's patient safety officer, and he's going to be doing your mandatory hand hygiene training. Dr. Kirchhoff?
Thank you very much. Thank you, Erin. Just so you know, Erin was the immediate past patient safety officer for Cooper Hospital, so I had some very big shoes to fill, and you were very lucky to have her in your midst. So, as Erin said, I'm Mike Kirchhoff. I'm one of the emergency physicians here, residency trained and went to med school here as well. And I'm going to talk to you today about hand hygiene. So a few things. One, I think everybody's seen this slide, or this face anyway, and have heard about this. So Ignaz Semmelweis and hand washing, right? I just want you to pay attention to the date. It was the 1840s. We got data, very good data, better than many randomized placebo-controlled trials that we have, better data than we often hang our clinical hats on every day. Clinical data that really showed that hand washing is one of the most effective ways to reduce transmission of disease in the clinical setting. Yet here we are today talking more about hand washing. So why now? Well, in 2012, 77,000 people, this is CDC data, nationally reported data, 77,000 people died from a hospital-acquired infection. Those are people we are, in part or wholly killing ourselves as healthcare providers. So it's really incumbent upon us, for those lives that have been entrusted to us, those families that come to us for help to take care of their loved ones, to really do our level best and take the best evidence from 1840s to do what we need to do for our patients. So why at Cooper is this a little bit more on the forefront? Well, it should always be in the forefront, but lately we've had this Acinetobacter problem. And you can see we had quite the spike there. And it's a significant spike, so much so that the CDC came out to help us look at it. And what's really interesting about the data is that if you look at this longitudinally, there's 4 genetically unique multi-drug resistant organisms that were found in this outbreak. And those unique organisms came into the organization, and then epidemiologically, we can track them to patients. So we, the healthcare system, we, the healthcare providers, are moving these organisms from patient to patient and causing harm, and hence my talk today. So we're not going to outrun this. We really need the tools. So what are the tools that we need? Well, hand washing is super, super important. This is data from 1978 that really looked at, well, when we let healthcare providers wash their hands without any instruction, what's the best that they do? And you notice missing fingertips, missing backs of hands, missing the thumb. Super important. We use our thumbs for a lot of things, including patient care, and we're going to take our dirty thumbs and move them from patient to patient. So when I talk about the next few things, I want you to think about this picture. I want you to think about the data from 1840s about how hand hygiene is the single best way we can prevent the spread of disease in the clinical setting, and take that important message to heart. So this WHO, this is worldwide. Countries all over the place are using these same techniques. And the US, being what it is one of the last to really adopt this. So this idea of hand hygiene, you're going to do your hand hygiene, and now I'm sorry, I have the mic in my hand, but you're going to rub palm to palm. And I want you all to do this with me. You're going to put the soap or your alcohol gel, and you're going to rub palm to palm, right? And then what you're going to do is you're going to dorsum. You got to get over the top of your hands. Get between, because remember in that picture, we're missing tops of the hands. We're missing in between. Then you're going to flip your hands palm to palm, but now you're going to go between the fingers. Because again, you're missing those web spaces all the time. Then we're missing the fingertips. So what I say, claw to claw. Get those fingertips. Then what was the big one we really missed? The thumb. So get those thumbs, both sides. And then those fingertips. Paw to claw. All right, so again, gel or soap, palms, let's all do it again. Backs of the hands and the web spaces on top. Web spaces in the front. Claw to claw, get those fingertips. But don't forget the most important finger, that thumb. And lastly, those fingertips. And for alcohol, you're going to do that until your hands dry, generally 20 to 30 seconds. By the way, 30 seconds is happy birthday twice. Or for the more cerebral in the group, it's the theme, the Final Jeopardy, beginning to end, including the 2 timpanis at the end, is exactly 30 seconds. Soap, you go a little bit longer, usually 30 to 40 seconds, but 2 happy birthdays will suffice. I prefer Jeopardy, but that's just me. So here's hand hygiene for soap, a few other things to remind you about how to turn things on and off, but essentially what I care about is make sure you get all those surfaces. So hand hygiene itself, I think it's pretty compelling, the data from the 1840s and the picture from 1978, that there's a definite why to how we wash our hands. But really, I think one of the things we're finding in the clinical situation is that the when is also very confusing to folks. So we started out by saying, well, gel in and gel out. Sounds really good, a great catchphrase, gel in and gel out. But what we're finding, especially with our Acinetobacter patients, is that when we're in the room, we're missing opportunities, and we're definitely spreading disease when we're in the rooms. I think in general, people are better going in and out of the rooms, but we're missing these opportunities. So the WHO has this other great idea, this idea of the 5 moments. So the 5 moments are, before you touch a patient, The proxy for that we use in our organization is crossing the threshold into the room. That's why we talk about entering the room. When you're entering the room, you're likely to touch the patient. And even if you don't intend to touch the patient, you may go in there and your fall risk patient might be standing up and ready to topple over. Guess what? If you didn't gel on the way in, your hands are dirty. So gel in before patient contact. The other opportunities are if you're going to do something that you really want it to be clean, you're going to access an IV, you're going to put in a central line, whatever it is that's aseptic, you don't want to transmit disease, you definitely want to gel before you do any aseptic techniques. The other opportunity is after any sort of contaminated risk or body fluid exposure risk. So if you're going to go in and help with a Foley bag, or if you're going to go in and adjust a Pleurovac, that's the thing for the chest tubes that drain, or if you're going to do wound care, that's another opportunity to get exposed to body fluids and contaminants. Anytime after a dirty or potential exposure, do a hand gel. And then the other opportunities are after touching the patient. I'm going to leave the room. You're going to gel to protect yourself, but also protect the environment outside of the room. Now, in our own data at Cooper, when we were just talking about gelling in and gelling out, while we had, pretty decent success rate, 60, 80, 90% at times, there was a huge disparity about when providers gelled. Does anybody want to guess, did we gel more going into the room or coming out of the room? How many for into the room, that was the better time? And how many for coming out of the room as the better time? Yeah, why do you think that is? Yeah, there's an intrinsic drive that, oh, I'm going to protect me, right? But we're really here. The reason you're here today, the reason I wake up in the morning, the reason I cross the threshold into Cooper and come in, is so that I can take the best care of patients. And really, we want to focus this on how can we best care for our patients and the families that come with them. And one of that is reducing infection risk, so the 5 moments. And then anytime you go into a room and touch the surroundings, the room becomes contaminated. So if you go in just to grab some papers, use the computer, when you're leaving, you definitely should gel out of the room as well. We consider the room sort of part of the patient. In general, there's a 3-foot bubble around the patient. You consider that the patient and anything in there is contaminated, but the room in general has the chance for that. So the 5 moments in before you touch the patient. Any aseptic technique, so anytime you're going to access an IV, put in a central line, whatever it is that you're doing that requires you to be clean, please gel. Anytime after you touch something with potential exposures, body fluid exposures, or infected wounds, etc., gel afterwards so you don't move it around the patient, you don't move it around the patient's environment. Anytime you're leaving patient care so that you're ready for the next time and you're not taking disease and pathogens out of the room. And then anytime you touch anything in the patient's surroundings. So those are the important things. Proper hand gel and soap technique, and also anytime, any of those moments. In and out of the room, clean procedures, you got dirty, clean afterwards, anytime you're leaving the patient, and anytime you touch anything in the room. All right, so here's some 5 moments cases. Because, people were very confused. When we started talking about the 5 moments, people were like, well, what if I touch a patient, touch a pole? What if I touch this, I touch that? What if I do, can I put the side rail down? So to make it very clear, one of the ways I like to talk about this is this idea of that 3-foot bubble around the patient. But to make it even clearer, let's go over some very specific cases. So you touch the patient, then an IV pole that's within 3 feet of the patient. Do you have to perform hand hygiene prior to touching the patient again? How many think you do not have to do hand hygiene? All right, how many people think you do need to do hand hygiene? All right, so you do not need to do it because it's within that 3-foot radius of the patient. It's got the same pathogens as the patient. Obviously, if it's soiled, it needs to be cleaned, you can do hand hygiene. But part of this is also level setting around expectations. It's hard. The work that you've signed up to do is hard. It's complicated, it takes time, there's many steps, there's a million little bits of information you need to keep in your head. And the last thing you need to do is to have to do all these repetitive tasks unnecessarily. So part of this education is also not only to tell you when to do it, but when it's okay not to. So if you're within that 3-foot bubble, as long as you're not going from a clean to a contaminated area like a body fluid exposure or a contaminated wound or something you know it's infected, or if you're dealing with urine or feces, then it's all the same. However, if you're in that 3-foot bubble and you do any of those things, anything that has a blood fluid exposure risk, anything that's contaminated, you need to hand gel again before you go back to the patient. So now you've touched the patient, then you need to access the patient's IV. Nurse is showing you how to push medications. So do you have to perform hand hygiene prior to accessing the IV? How many say no? Ooh, good. How many say yes? Excellent. Yes, it's aseptic. And there's actually a lot of stuff around here. One thing I like to tell students and residents is that when you look at how other people do their work, when people are good at their work, they make it look easy. And nurses are no different. Nursing workflows to the uninitiated look simple and easy. It's complicated. They have a lot of little tasks that they need to do. There's a lot of the why in what they do. And they don't just stick IVs on, they scrub the hub. And they have to scrub for 30 seconds. And there's certain types of hubs you use. And how do you push the med? And how do you make it not reflux back into the bag? And how do you make sure you have the right medication? How do you make sure you have the right patient? What speed am I supposed to be pushing this med at? Suddenly, nursing is very complicated. So the other thing I just want to point out here is that we all have very complicated jobs, and this really just points to one of those things. So yes, hand hygiene prior. So you've entered a patient's room to get your notes off a computer. That's like on the other side of the room. This greater than 3 feet away. Do you have to perform hand hygiene upon leaving the patient's room? How many say no? How many say yes? Yes, absolutely. You touch the room, you got to clean. You've entered a patient's room and adjust the pleurovac. That's the little thing that does the chest tube that drains the bloody stuff out, the body fluids. So now, do you have to perform hand hygiene prior to touching the patient after you've touched the pleurovac? How many say no? How many say yes? Yes, so it's a potential exposure. You gel before you touch the patient. All right, so this is one other thing I want to add and explain some of the other policies that we have. I think part of this roadshow is to explain not only what and how and when, but the why. So we have Acinetobacter in our hospital, and the CDC came and they've isolated it from many places. I'm just going to give you the answer to this because you wouldn't necessarily know. But we have isolated Acinetobacter from hard, non-porous surfaces. So hard, non-porous surfaces are things like this. You would think, people are wiping it, cleaning it all the time. Well, how is there Acinetobacter living on that? Well, Acinetobacter it's a very hardy organism, lives all over in the environment. Acinetobacter baumannii is actually not as ubiquitous as the genus in general, but it is as hardy as its cousins. So the reason I bring this up is because it lives in the environment. So this is why it's important when you're doing your rotations or doing a week on the wards and you're going to the OR, and they talk about scrubs and putting your cover up before you leave the OR. It's because Acinetobacter is just in the environment. If you leave a clean space and go out in the environment and you're relying on your uniform to protect your patients, you got to protect your uniform. So that's why we need cover-ups. That's why you need the proper shoe coverage, because those organisms live in the environment, and you'll bring them back to these locations that is very dangerous for these bugs to live. So universal precautions, just a quick little spiel on that. It's basically everything you should be doing for every patient. Hand hygiene, personal protective equipment when you're doing tasks. We'll spend a couple minutes on that. That's not the main thrust of this talk. Respiratory and cough etiquette, so coughing, sneezing into the elbow, turning away, not coming in when you're sick, wearing a mask, etc. Sharp safety, safe injecting practices, making stuff clean and sterile in the area, and how we clean and disinfect the environmental surfaces. And really, that's one of the other things I just wanted to talk for. So before we talk about equipment, I just want to talk about something else to keep you safe and keep our patients safe. This isolation. So this idea of transmission-based precautions. So we talked about universal precautions. Now we're going to talk about transmission-based precautions. And you're going to look for these signs in the clinical environment. See a nice little stop sign there? So that's going to tell you, look for these red signs. In some units, the isolation carts are inside the room because it's in a drawer. So you may learn visual cues on some units, but not other units will have the isolation carts out. So you need to look for these signs. These signs will tell you the types of isolation, which honestly you don't care about unless you're ordering it. What you do care about is what is it telling you need before you go in the room. And you need to use all of these if you're going to enter the room. So whatever there's a picture of, use it. And when you're done, it tells you how to exit. I'm not going to go into PPE. I included the slides here, but that's not the intent of this lecture. It's really hand hygiene, but I included personal protective equipment, so when this goes on the web and you're learning commons and all that stuff, if you want to access it later on, you can look at PPE. But what I did want to talk about is, we'll skip all that because we don't have time to do all this. So I just want to talk about stethoscope and equipment cleaning, because this you will definitely deal with. So our recommendation for stethoscopes is, if somebody's in isolation, use a disposable one in the room, not yours. For general patient care, clean it before and after each use with the 70% isopropyl alcohol wipe. There's actually a little bit of literature using hand gels, but the better literature is on the wipes, so carry wipes with you and use that. Wipes can dry in 10 to 15 seconds. The 70% isopropyl alcohol is effective in those short time frames. And then general principles for shared equipment cleaning. The reason I include this here is you're not moving x-ray equipment around, but what you may be using is a workstation on wheels, a WOW, a computer, that you're moving from here to there. The recommendations there is clean it with the approved wipe. Usually on computers it's the gray wipe because they're not alcohol-based. And you wipe before and after your time with the machine, so before and after your shift if you're working clinically. And then high-touch areas between every patient use. So you clean your WOW nicely before you get started, because who knows where it's been. You don't want to get sick yourself. You don't want to move stuff from unit to unit. And then every time in between use, provided it doesn't become visibly soiled, all the high-touch areas, keyboard, the mouse, the handles, and that's important after each use. Or if you're in a room and you accidentally touch the patient and then touch the computer, now the computer's contaminated, you need to clean that. So that would be also an opportunity to gel in between. I use a WOW when I see patients. So what I do is I keep my WOW 3 feet away from the patient care space. And then if I'm moving from the patient back to the WOW, I'm moving from something that might be contaminated or a carrier, might have a pathogen, to an area that I want to keep clean and not move. So I'm gelling after the patient, because that's after patient care. It's not out of the room, but it's after patient care. I care for the patient. Now I'm going to document and talk to the patient about my findings or my recommendations. I'm gelling before I touch my computer, so I'm not cross-contaminating my computer. And I don't know what's on my computer, so now if I'm going back to patient care, I'm gelling again. So you see how quickly this becomes complicated, and you really need to be thoughtful about how you approach patients, especially when you're using equipment. So that's really what I wanted to talk to you about today. Hand gel, the technique, make sure you get those web spaces, fingertips, thumb, use the WHO guidelines, the 5 moments of hand hygiene before patient care. Anytime you're going to do something that requires you to be clean, like aseptic techniques, etc. Anytime you touch or potentially have touched something that's contaminated or body fluid exposure, urine bags, wounds, etc. After that. After patient care, so you don't bring it out of the room, and anytime you've touched anything in the patient's room, even if you don't touch the patient when you're leaving the room, gel your hands. Stethoscopes, wipes, 70% isopropyl alcohol, it's the ones we use when we're given IVs. Rub the bell in the high-touch areas before and after each patient use. And then if you're going to use a WOW, clean it thoroughly before and after your shift, and every time after patients on the high-touch areas, the keyboards, the mouse, etc. And that's true for any other equipment. If you've got an otoscope with you or anything like that, it's good practice to clean that. And remember, you don't want to bring this stuff home, so don't forget to clean at the end of your shift. Any questions, thoughts, concerns, heartburn about hand hygiene?
I don't know how often a physician goes into patients' rooms, but I know that as far as like nurses or nurses' assistants, they can easily go in a 20-patient room in an hour. That's a light shift.
Yes.
You're considering just at a minimum washing your hands before you go in there. And when you come out of the room, that's 800 seconds. That's 13 minutes in an hour.
Yep.
On a 12-hour shift, that's 2.5 hours you spend washing your hands.
Yes.
And that's just the minimum.
Yes.
How do you achieve this? How is this possible?
Proper resource allocation and work balance and support and resources for the nurses. Ubiquitousness of the gel. One of the biggest issues we had is now add to that when we only had gel on the desk or at the end of each hallway, which was a problem when we first started this endeavor a couple of years ago. Not only did it take them the 30 seconds to gel their hands, but it took them the 20 seconds to walk down to the end of the hall, do their gel, and come back. So making the good easy and the hard difficult, and also realizing that to ask people to do the right thing, you have to give them the right resources. So there's an understanding that tasks have to be ordered in the right way. You have to make sure you have the right number of resources on the unit to make sure that you don't have other waste. So I'm not going to be able to limit the 20 to 30 seconds it takes to gel, but I can eliminate the 20 to 30 seconds it takes to walk down the hallway to get gel. So to really look at that whole process. But you're absolutely right. To do this well is really, really difficult. And we just need to keep looking at the process and make it better. And we also need to look at the resources everybody has to make sure they have what they need. But a very good point. Any other thoughts, concerns? Yes?
Where do gloves play into the picture? Like when gray gloves, you something to wash your hands often.
Yes. Good question. So gloves in general is considered part of standard precautions for the most part. You put it on whenever you have a risk of body fluid or infectious exposure. We ask that you gel or wash your hands before you put gloves on so you're not contaminating the glove box. And when you take your gloves off, you had the potential of contaminating bringing what was on the outside of the glove onto your hands. So we ask you to gel or do hand hygiene after gloves. So as one can imagine, you add this in now. I'm doing procedures where I'm going back and forth, putting gloves on, taking them off. It can become very inefficient if you're not careful about how you sequence your work. So, but gloves for the most part, part of standard precautions when you're worried about infectious or body fluid exposures. And certainly if something's going to be wet, you're transferring fluids, et cetera, then you need to also think about from the terms of standard precautions and personal protective equipment, not in the setting of isolation, but in the setting of even non-contaminated blood, et cetera. Splash guard, face and eyes and mouth, and also impermeous gown if it's going to be large volume. So there's a lot to think about. And I would encourage you to ask these questions. I think part of the problem is that we just haven't been talking about this. We just assume people know how to wash their hands. And there's a science to it. And people clearly need guidance and clearly have questions. There's a lot of details. So I encourage you to speak to your mentors, talk to the nurses, talk to the unit managers about how they want you to behave on that unit and tricks and information that they can give you to help you do your job better. But that's an excellent question. I don't want to take up too much time because I think you have a break coming up. Any other questions?
I'm just going to make a comment. So I get this question from medical students a lot, and it relates to culture. So a student will say to me, I'm just a medical student, but I saw somebody not wash their hands, a very prominent physician, that physician may be grading me. What's my responsibility? So Dr. Kirchhoff and I have done a lot of work collectively on safety culture at Cooper.
We have a ways to go.
And you know, what I want to say to you is that we are promoting speaking up. So you may get feedback from others on your team that you have not washed your hands. They may point that out to you. Similarly, you have the right to point that out to them. Now, there's a way to do that respectfully. There's a way to do that. Sometimes I'll slip somebody the gel and just, you know, give a wink, right? Like, here, you forgot that, right? So there's a way to do it. I also think that if you hear that yourself, you know, please take that as a teaching moment. Because at the end of the day, we are trying to protect our patients, and we know that this is the best way to do that. So I wanted to put that out there. Please feel empowered to speak up if you see something.
Yes, we are asking. We're actually doing explicit training over the next 2 years to really instill this in the staff. So that we're actually doing training about various patient safety tools, and this is one of the tools to really insist that staff speak up for the best care of their patients. And it's already part of policy. It's a zero tolerance policy for retaliation against anybody bringing up any patient care issue. I will hope that this will never happen, but when it does, if you at any time ever feel like somebody even looked at you funny because you were advocating for your patient, please let me or Aaron know about it. In the past, this hasn't happened recently, but in the past, there's been some providers that really didn't take kindly to it, and we very much came down very hard on them. It's part of our policy. It's unacceptable. We want to take the best care of patients, and anybody should be able to tell anybody if they're violating policy. I hope that won't happen, but we have your back if you even hear rumblings, because it's completely unacceptable to not take feedback in order to take the best care of our patients and their families.
Great. So thank you, Dr. Kirchhoff. We really are honored to have you here with us today. I appreciate your time. Okay, thanks, everybody. You're free to go. Don't forget to badge in if you're here.